System online. Well, hello there. I am VASI, the vascular artificial intelligence created by Dr. Mohammed Almar El-Farak, initializing your FRCS mastery module on ischemia reperfusion injury. We're extracting this explainer directly from Rutherford's Chapter 6. This is an absolutely crucial topic, not just for your exams, but for your future practice on the wards, so let's get perfectly aligned on the pathophysiology.
All right, FCS candidates, initialize your memory banks. Let's quickly map out today's micro to macro data download. We're going to hit the 1-2 punch of the injury itself, the microvascular defense breach, cellular demise pathways, the chemokine surge, and finally, those high-yield clinical scenarios. Section 1, the 1-2 punch. Let's dive right into the fundamental concept of ischemia reperfusion injury, or IRI. Ischemia reperfusion injury is literally the biological equivalent of a well-executed 1-2 punch in boxing. It's a great analogy. The tissue is first stunned and starved by ischemia, which essentially sets it up for the massive knockout blow of oxidative stress the absolute second reperfusion happens. Because that second punch is directly tied to the severity of the initial ischemic event, limiting ischemia time is and always will be your paramount clinical goal. Okay, moving to Section 2, microvascular defense breach. Let's see how the vascular endothelium becomes an early casualty. Normally, the vascular endothelium provides this nice, smooth antithrombotic passage, right? But during IRI, it is incredibly vulnerable. Let's look at the arterioles first. Here, increased arginase activity completely exhausts the L-arginine pool. And without L-arginine, you destroy nitric oxide synthesis. Without nitric oxide mediating vasodilation, you're left with a vicious cycle of vasoconstriction, sluggish flow, and terrible malperfusion. Moving downstream to the capillaries. Now, definitely flag this for your exams. You have to remember the no reflow phenomenon. Basically, endothelial barrier dysfunction narrows the capillary channels. Then, these rigid, non-deformable leukocytes get trapped in the narrowed spaces, completely obliterating any distal tissue perfusion. It's like a microscopic traffic jam that just won't clear. And then we get to the venules. This is where the canonical inflammatory response really hits its peak. It's mediated by xanthine oxidase and matrix metalloproteinases, specifically MMP2 and MMP9. These guys go in and destroy the endothelial glycocalyx, which promotes massive neutrophil extravasation and the systemic diffuse edema that ultimately leads to severe hemodynamic instability. Section 3, cellular demise pathways. Let's scale down even further to the microscopic level. We need to decode the exact cellular changes happening during prolonged anoxia, and this algorithmic progression is a huge point of examination. Step 1. Oxygen drops, ATP depletes, and lactic acid spikes from anaerobic glycolysis. Step 2. To buffer that dropping pH, the sodium-hydrogen exchange accelerates. This pulls sodium, and water right along with it, into the cell, causing hydropic swelling. Step 3. Prolonged anoxia inactivates your ATP-dependent calcium pumps, so you get this massive intracellular calcium buildup. And finally, Step 4, all that calcium overload triggers destructive calpain and proteinase activation, leading straight to hypercontracture and cell death. So how exactly does this cell death play out? You've got to distinguish between the two paths for the FRCS, apoptosis and necrosis. Apoptosis? It's highly orchestrated. It's an intrinsic, gene-directed pathway driven by the mitochondria using BAX and BAC to release pro-apoptotic factors. Necrosis, on the other hand, is just pure chaos. It's flooded with reactive oxygen species, TNF receptor signaling, and the opening of the mitochondrial permeability transition pore. The whole thing ends in massive membrane fragmentation and incredibly violent inflammation. On to Section 4, the chemokine surge. Because as blood returns, oxygen paradoxically becomes a destructive fuel. It initiates a massive systemic chemokine surge. And, this surge isn't just an acute emergency, it dictates the pathology of chronic conditions too. Just consider a patient with peripheral arterial disease. As they walk and rest, they are undergoing these repetitive, low-level cycles of hypoxia and hyperoxia. This continuous ischemia reperfusion injury drives ongoing apoptosis, mitochondrial dysfunction, and ultimately severe myofibril atrophy and fibrosis in their sphaleovessel. You will definitely want to download this high-yield data into your cortex. These specific circulating mediators dictate the systemic cytotoxicity that follows reperfusion. Endothelin is acting as a potent vasoconstrictor. Conversely, adenosine and adrenomedellin are your endogenous vasodilators that actually inhibit ROS and complement activation. And don't forget heme oxygenase. It gets rapidly transcribed under stress to downregulate those pro-inflammatory cytokines.
We also absolutely cannot forget the complement cascade. It is equally critical. Whether it's activated by the classical, alternative, or mannose-binding pathways, it operates like a systemic biological weapon. The cleavage of C3 triggers acute inflammation, but the real kicker is that the cascade ultimately deploys the membrane attack complex, or MAC. This complex directly ruptures and destroys surviving cells through lysis and opsonization.
All right, moving to our final section, high-yield clinical scenarios. Let's see how this plays out in the OR.
When you are assessing myocardial IRI, you must distinguish between stunning and hibernation. Stunning is essentially a temporary paralysis. It's a prolonged abnormality in myocyte contractility from calcium overload and oxidative stress, but, and this is key, it is entirely reversible. Hibernation, though, is an adaptive preconditioning. The chronic intermittent ischemia actually primes the myocardium to resist extended ischemic events by altering its gene expression.
So let's review the actual data on manipulating with preconditioning. Despite all the really promising theories, the major clinical trials have been kind of humbling. The Dynami 3 iPost trial tested post-conditioning, but it failed to demonstrate reduced death or heart failure. The Dynami 3 deferred trial, it showed deferred stenting was not superior to immediate stenting. And even remote ischemic preconditioning, or RIPC, where you use blood pressure cuffs on limbs to protect the heart, has shown very mixed results in vascular surgery patients without a clear, universal benefit.
Switching gears to acute limb ischemia. When you reperfuse an ALI, it triggers massive muscle swelling. And the systemic release of myoglobin and potassium, that can easily throw your patient into acute renal failure and severe hemodynamic compromise. Now, the CRAIL trial actually attempted to mitigate this using controlled reperfusion with a cardiac buffering solution, but it demonstrated no difference in amputation rates. So the key takeaway here, the raw extent of the ischemic area remains your absolute strongest predictor of eventual amputation, regardless of any novel reperfusion techniques.
Now for a true surgical emergency, compartment syndrome. Mattson's arteriovenous pressure gradient theory explains that as interstitial pressures rise, venous outflow stops, and eventually, microvascular blood flow completely ceases. You have to remember the two-hit inflammatory model. The first hit is the initial ischemic event, sure, but the second hit is a massive surge of TNF-alpha and cellular debris the absolute second you perform that life-saving fasciotomy. The timeline is strict, folks. Neuropraxia begins at just 1 hour, and irreversible necrosis sets in past 6 hours.
Finally, let's talk about aortic clamping. Placing a clamp creates a profound systemic vascular resistance shift. Taking it off initiates relative hypovolemia and washes vasodilators, like lactate, directly into the systemic circulation. This dangerous, rapid fluctuation heavily endangers the spinal cord. Neurons simply do not have the resilience to handle prolonged ATP depletion. This highlights the absolute necessity for controlled unclamping and for solid hemodynamic support from your anesthesia colleagues to prevent permanent spinal cord injury. As you wrap up your FRCS exam prep, I want to leave you with one final data point to process. Discovery Science is aggressively targeting the mitochondrial permeability transition pore and specific necroptotic signaling cascades. So how will targeting these very molecular pathways redefine your future standard of care? Will we one day be able to completely neutralize that devastating second punch of reperfusion? It's something to think about. This concludes your VASI Mastery module on ischemia reperfusion injury. Keep your focus sharp, trust your training, and good luck with your continued preparations.